to another Friday edition of VMR. It is still RLR, except one R has been substituted because he is on vacation celebrating his birthday. And I couldn't think of a better R to co-discuss with than Ravi. Ravi, how are you, friend?
Oh, doing well, doing well. Glad to be sharing the hot seat with you today. So hopefully it's a lukewarm seat, but excited to hear from Franco, see what he has in case for us.
Yes, we got Franco presenting, which is always an exciting event. I'm actually a little anxious, to be honest. And then we got the wonderful Gabrielle scribing and the amazing Shema, who's going to be doing some teaching points. So without further ado, let's get started. If you want to take over the screen, Gabrielle, and then Ravi, if you don't mind, jumping in the hot seat first, and then I'm here and we'll play ping pong, my dear friend.
Absolutely.
Okay, perfect. So I hope you will find this case interesting. So the chief concern is persistent fever after abdominal surgery. Do you need more info, or should I go for the HPA also?
I think we could stop there. This is actually quite a common complaint or a scenario that we do see, especially on consult service. I know, Reza, you've been on consult service, so you had a couple of cases. Commonly post-operatively, we do get called for fevers, and this is where I kind of would jump into what could you have post-operatively. You have these 5 W's that we all learned in med school. You know, the water, wound, water, walking, and waves. Actually, waves would be MI. I forget the which one is in which order. Wonder as well, Rafa mentions. I see in the chat. Actually, I should open up the chat to get some pointers from. So what I did here was waves could be a post-op MI that can happen immediately. Water would be UTI. Wind would be atelectasis, but that isn't an entity that we do see. You could possibly have pneumonia, especially post intubation. And then the wound infection would be something down the road, 5 to 10 days. And then walking, you would also have something like a DVT. And that actually does cause, I remember, Reza, one of your tutorials, you said that was actually an entity that you do see. So sort of a mnemonic that we could use post-operatively, but I would be very systematic. I think we'd have a tendency to linger around the wound. So what did this patient have or just underwent? Abdominal surgery. So we would immediately focus our attention to the site of surgery, and then look for any complications, and wound infections or post-operative issues surrounding the wound would come to mind. I'll pass the mic to you, Reza, if you have any thoughts.
Nothing else to add. That was very comprehensive. Thank you, Ravi.
Perfect. So for the HPA, this is a 17-year-old female that was transferred from a regional hospital with a history of persistent fever after abdominal surgery. So initially, she had intermittent fever for 15 days, along with poorly localized colicky abdominal pain. Later, while the fever persisted, the pain increased in intensity and localized to the right lower quadrant. At that time, in the regional hospital, they performed an abdominal CT that showed contained appendicitis. Initially, it was managed conservatively with broad-spectrum antibiotics, but due to persistent fever and hemodynamic instability, they performed a laparotomy due to probable peritonitis. So the surgery went well. They only found the contained appendicitis, but post-surgery, the fever persisted. It never went out. And in addition, on the last day on her stay in the regional hospital, she developed new onset of jaundice, hepatomegaly, perineal ulcers, and rectal bleeding. So after stabilizing her, they transferred her to our care.
Wow, Franco. You never cease to disappoint. We got so much additional data here. And maybe what I'll do is I will tackle everything up to the jaundice, hepatomegaly, and other findings, and then play a little ping pong with my dear friend Ravi and see what his thoughts are. But we have a young patient, 17 years old, who's presenting with persistent fever and abdominal pain. And the way we can frame this is in two ways. One, the appendicitis that was initially conservatively managed with antibiotics was the cause of the original fever. The patient underwent surgery and now is having complications of that surgery, leading to continued fevers, but of a different origin. That's one way to frame this. Another way to frame it is that the patient had fevers and abdominal pain that are not related to the appendiceal pathology, meaning either it was the wrong diagnosis on imaging or in itself did not solely explain the patient's original fever. And so you did the surgery, but since that wasn't explaining the original fever, it had not resolved the patient's fever. So these are really, I think, the two buckets that I'm thinking about. And there are reasons to question that original hypothesis, which was later shared by Franco. So it's going to be very crucial to go back and evaluate that additional imaging, but more importantly, to use the other clues to make more progress on this case. Because what Franco just did was give us multiple pivot points. There isn't just one pivot point in this case. So for that, I'm going to pass the mic to my dear brother, Ravi.
Yeah, absolutely. I have the same concern. You have a young female with abdominal pain, and this scenario plays out many times across many emergency rooms, and we straight away consider appendicitis as a possible differential. And many times actually I've seen that many of us may perform premature closure and just anchor onto that, and that sometimes ends up with surgery, and after the surgery the complaint still continues or actually may get worse. So this is actually an exercise where I'd be very concerned that was, like you had highlighted, was the original diagnosis the correct diagnosis, but now you have, like you mentioned, multiple pivot points that actually this may not have been the pathology of concern. So now with rectal bleeding, with jaundice, now we have to focus our attention. You know, they already done the surgery, so we've moved the appendicitis out of the picture. Now we need to focus in on, is it the GI tract? Is it the hepatobiliary tree? Where is the focus? And I guess as we obtain more data, especially starting with maybe medicines, with the physical exam and then the laboratory data, we can then focus in on what really is going on with this patient. Anything else, Reza, you'd consider?
You know what's amazing, Ravi? Rafa just texted me. He says he thinks I'm saying Robbie, but it's not only that I'm just co-discussing with another R. It happens that R's name is like the other R's name, Ravi and Ravi. I agree completely with you. And the interesting thing here, Ravi, is that with the jaundice, like usually when someone has jaundice, I take that as a major pivot point, and I try to unleash like an approach to that jaundice, meaning my mind converts it to hyperbilirubinemia, and then I ask, is it direct or is it indirect? Indirect being causes like hemolysis, and direct being, hepatobiliary obstruction. The hepatomegaly is one thing that makes me more prioritize a direct hyperbilirubinemia over an indirect. The other clues that you can use for prioritizing direct over indirect, just from the history alone, is stuff like dark urine, because bilirubin in its indirect form is, water insoluble and won't get filtered through the kidneys, but in its direct form can actually reach the kidneys. Additionally, if the patient had like acolic stools, that would also suggest, some kind of hepatobiliary obstruction. So I'm very interested in like the perianal ulcers. That's a unique finding. This is not like an ulcer located on the toe that we see in our patients with diabetes and neuropathy, or an ulcer we see in patients that are older with venous stasis or with peripheral arterial disease. This is like an unusual location and a young age. I don't have the best DDX for perianal ulcer, but like a couple conditions that come to mind. One includes inflammatory bowel disease, specifically, Crohn's disease. And then I try to think, well, could there be some GI abnormality, extraintestinal manifestations that might be suggestive of this? The other mimicker of Crohn's I think about is, Behçet's. Hard to like unify everything with that, but I guess the point I'm just trying to make here is that those ulcers are a weird location. The patient is young. It really makes me start thinking about some kind of autoimmune phenomenon. And then, thinking about the jaundice. Ravi, anything to add on to that? Or what do you think about that?
Oh, absolutely. That's remarkable there, especially that these ulcers actually may be a signature to more internal disease. Like they say, the skin reflects internal disease. So this sort of has a inflammatory flavor to it, especially that the patient's been on antibiotics and there's been no resolution, no effervescence of her condition. So that makes me consider alternative theories, which one could be an inflammatory bowel disease or just, quote unquote, an inflammatory disease. So again, we'll see what Franco has in mind, or what more he can give us to really then chew on to narrow down our focus. Because right now, we can just do so much cognitive legwork and trying to break down each of these disorders, but then we'll burn through the hour mark. So I guess as we get more information, we can then zone in on what could be potentially going on. Franco?
Perfect. So regarding the previous medical history, besides the antibiotics, she wasn't taking any meds, like prescriptive meds, but her mother told us that during the past year, she had been taking protein supplements and so-called fat burners, and she was engaging in intermittent use of laxatives in the weekends. Regarding family history, no family history, no social history, and she had allergies to sulfonamides. From the bio, she was feverish with 39.5 Celsius. The heart rate was 120. The blood pressure was 100/50. Respiratory rate 23. And SpO2 was 95 on room air. In the initial physical, generally she looked appearing. She looked ill with subtle jaundice and really thin. Each ENT, she had icteric sclera, but no lymphadenopathy. Cardiovascular was tachycardic with regular rate and rhythm, no heart murmurs or gallops. Pulmonary lungs were clear to auscultation bilaterally, no other signs over there. Regarding the abdominal examination, there was a slight tenderness to palpation across the abdomen with no guarding, no rebound, but there was palpable hepatomegaly and splenomegaly. Bowels were present, and the surgical scar was okay. It wasn't irritated or something like that. Neuro was unremarkable, and the skin was with a slight jaundice, no rash, and there were multiple perineal ulcers. Yeah, I can stop there.
Ms. Reza, you want to tackle the exam? There's quite a bit of findings there.
You got it, Ravi. And I would love for your feedback and anything to add. I'd appreciate that. So right away, we notice that the patient is inflamed. You have a high temperature, which is the most specific marker of inflammation. And appropriately, through Liebermeister's rule, the patient is also tachycardic. I don't know if anyone should ever say Liebermeister's rule. It's one thing to say Fagett sign, but this is like an obvious like 8 beats per minute rise in the heart rate with every 1 degree Celsius rise in the temperature. The tachypnea is interesting. It makes you wonder, could there be something in the lungs? Although Franco told us that the lungs were clear, we're not that sensitive in picking up, subtle findings within the lung, because right now what Ravi and I are trying to do is sort of determine which organs have pathology. And then once we determine that, then we'll be able to list some diagnoses that can map on to the organs with pathology. But the patient could be tachypnic from, for example, a lactic acidosis and have clear lungs. In this patient, I would definitely obtain a chest x-ray because that oxygen saturation also isn't totally normal. We learned that recently from Charmaine and Jack that actually Angelina pointed out on a case that was discussed yesterday, a very interesting case by Sammy. Here, the sclera are yellow. It tells us that the bilirubin has to be north of 3. With the liver being enlarged, it tells us it's likely going to represent direct hyperbilirubinemia, but I'll still have a close eye to that hemoglobin, and we're going to fractionate the bilirubin. Anytime you're dealing with an enlarged liver, you can ask the question, is it due to congestive hepatopathy, for example, in the setting of heart failure? Or is it due to inflammation, for example, when you have hepatitis A? Or is it due to something infiltrating the liver? That infiltration of the liver is an interesting thought because this patient does not have heart failure, at least based on our exam. And there's no reason why inflammation of the liver would necessarily lead to inflammation of the spleen. So I think something potentially like infiltrating the liver and leading to portal hypertension, possibly causing the splenomegaly. And whenever you have splenomegaly, the thing to start with is ask, is there water in the spleen? Meaning, is it portal hypertension? And you can divide that into cirrhotic and non-cirrhotic. Here, there's no evidence of chronic liver disease, the stigmata like pulmonary erythema, spider angiomata, caput medusae, the hyperestrogenism. So it seems like it's more on the acute side or non-cirrhotic portal hypertension. And there, it's either non-cirrhotic portal hypertension or it's, stuff that's invading the spleen. And you guys can think of a bunch of viruses, infections, cancers, and such. And then finally, you have these ulcers, which, from the start, it really grabbed our attention as being unusual. And I feel like has to serve as a pivot point. And there is, I think, Ravi, that this disease entity primarily is involving the GI tract. And the fact that the patient was diagnosed with appendicitis, maybe it's mimicking appendicitis. So telling us that it's involving not only the perirectal region, but also north of that, meaning not just confined to the sigmoid colon and the rectum. And so I think the primary signature is in the lumen, but it's leaving its mark elsewhere in the liver and maybe even the lungs. But I'd love to hear what you had to say, Ravi. There's a lot of data here, and it was hard for me to really, organize it.
Yeah, absolutely. While you were just running through your thoughts there, I was trying to connect the dots, and it's still not. It's still very unclear. You have multiple things going on, but I'm really interested in the labs. I really do want to know what the hemoglobin is, because at this age, I can't help but just wonder. You went through a nice walkthrough of different infections, and I assume this patient, Franco's from Peru, so this patient could have infections that could be seen in Peru, brucellosis, schistosomiasis, other sort of cases that we've had on VMR before. But could this also be a signature of extra medullary hematopoiesis? So at this age range, could there be leukemia, lymphoma, and thus that could explain the hepatosplenomegaly as well? So that's what I kind of have on my mind. But I guess we'll see what the data has in store for us, and then we'll focus in on what's abnormal. But yeah, just going back to the labs too. This is a markedly sick individual, especially like you mentioned, the fever and the tachycardia and the blood pressure sort of borderline. It's low. And again, that was a really good remark that I also agree. I don't see any signature of liver cirrhosis. So this hepatosplenomegaly must be some sort of infiltrative disease, and we'll see what the labs have in store and what may help us further focus in on the diagnosis. Franco?
Well, we were just in the same way that you were thinking about. There are multiple things going on. So I think the labs are going to give you a little more
Hey, Robbie, it's always a good
narrow.
sign when the presenter was thinking like us. That's like a little check.
Okay, so the hemoglobin was 7.6. The leukocytes were 1,083. With 8% of those lymphocytes were atypical. The platelets were 22. Potassium was 2.7, sodium 151. The total bili was 9, direct 8.66, indirect 1.06. The alkaline phosphatase was 266. The GGT was 349. Albumin 1.92. Globulin 3.63. The creatinine, BUN were within normal limit. There was also HIV negative, hepatitis B, hepatitis A, hepatitis C negative. The AST and the ALT were within normal limits. We also take acid-fast bacilli because we were from Peru, so the acid-fast bacilli was negative in sputum, urine, and feces. The ferritin was in 5,000, triglycerides 279. And I think, there was also an abdominal CT that shows severe hepatosplenomegaly with some degree of lymphadenopathy and the post-surgery changes. There were no gross tumors present in the abdominal. And I think I can stop there. If you need something else, just tell me.
No, I think Ravi wanted the data and he knew that it would be very helpful. And here, once again, we have so much data that it's very difficult to process in real time. And I'll break this up so that we can take it in piecemeal fashion. Ravi, do you want to tackle the CBC? And I can maybe start by commenting on some of the chemistry abnormalities, and then you can fill in the gaps from there.
Absolutely.
I think when we approach this chemistry, the sodium of 151, this is not a pivot point, folks. The patient's hypernatremic. There's only one requirement to hypernatremia. There's one requirement. Remember, hypernatremia, you're looking at a concentration of sodium over water. And it's always a water issue, almost always, unless you're stranded in the middle of the sea and you have nothing to drink and you're drinking the seawater. But this patient, to become hypernatremic, you have to lack that desire to drink, because hypernatremia is such a strong stimulus for both thirst and vasopressin secretion. So right away, like looking at this sodium tells me that the patient isn't drinking enough, but it could be that and then you have to ask, why isn't the patient drinking? And in a patient who has jaundice and is not drinking enough, you have to think about acute liver failure. So this is someone you got to look at the INR. But what makes acute liver failure unlikely is the AST and ALT are not that elevated. So I would be curious why the patient isn't drinking enough. So they may have an additional insult like a diabetes insipidus or fluid loss from the GI tract in the form of diarrhea that hasn't yet been reported. So then you look at the AST and ALT being normal was quite surprising to me. I was expecting some form of elevated liver enzymes, but I think it's quite telling too that whatever this process isn't really causing hepatocyte damage. this isn't a patient with like long-standing cirrhosis that wouldn't have an AST and ALT response to something that's, invading or troubling the liver. But with this alk phos elevation, and I believe the GGT, yes, is also elevated, you can categorize the liver chemistry abnormality as isolated alk phos elevation. And that really does prioritize an infiltrative process. And so you can have infiltration of the biliary caniculi that's not causing any trouble to the hepatocytes. And that's why the AST and ALT are normal, but the alk phos and GGT are elevated. Because remember, if you look at the chart of what you expect to go up first, the AST and ALT usually rise before the alk phos and the bilirubin when you have pathology of the liver. So in any case, I think this is consistent with infiltration. The ferritin being elevated is just telling us that this patient's inflamed. It doesn't specify a specific diagnosis like HLH, hemochromatosis, adult onset still disease, or an infectious process. But with the triglycerides being elevated, the ferritins being elevated, and some of these CBC abnormalities, it's hard not to say HLH. But even if you say HLH, you have to ask the question, why HLH? There's secondary causes of HLH, from lymphomas to autoimmune diseases to viruses like mononucleosis. I'm sure I'm missing stuff, and it's like a lot of data. So I'm really looking forward to Ravi adding to my discussion and tackling that CBC.
Yeah, that was a great walkthrough of the chemistry. Again, yeah, the AST-ALT, just piggybacking off what you mentioned, I was surprised that that's normal. And the ALP, I guess it's not markedly elevated, but it isn't within the domain to think about infiltrative disorders. But that bilirubin is really high. That is signifying definitely something going on in that area. I was wondering about the hemoglobin, now focusing on the CBC. Could the hyperbilirubinemia be secondary to hemolysis? But we have mainly a direct hyperbilirubinemia here. But looking at the white cell count, Franco, is this was it 1.8? It's low, right? It's not 18,000, is it? Am I reading it correctly?
In the white blood cells or what?
Yeah, white blood cells.
Yeah, they were low.
Low. Okay. So and this 8%, so it's like somebody had mentioned, there's significant pancytopenia here, and this atypical lymphocytosis is interesting. What could that be? Could that lead us to some abnormality? Where do we see atypical lymphocytosis? So this could be something along the lines of, HIV could cause something like this. I think hepatitis can cause it, CMV, EBV. Could this be explained by a viral disorder? But there's so much going on here. I don't think a virus could explain this much, but it's definitely something to put on our radar screen. The hemoglobin, surprisingly, 7.6, not terribly low, but still low enough for a 17-year-old. And then the platelet dysfunction, or the platelets are also low as well. So this pancytopenia, so we have one domain of infection, inflammation with downstream effects on the bone marrow. Likely, I think this is something going on the bone marrow. Doesn't look like there's any medications that could be causing it. So again, focusing on the bone marrow, is there something external? Is there something within the bone marrow that's causing this? And with one leg or one arm within the hepatobiliary tree as well. So we got like 3 processes going on, trying to link them. I'm still sort of foggy what could be causing all these issues. But Reza, any idea? I was thinking malaria at some point with the hepatosplenomegaly, but less likely. I mean, there were some great thoughts, leishmaniasis, and in the chat too, brucellosis, but it doesn't explain this though.
Ravi, just listening to you, I loved how you unpacked the pancytopenia. And I think right here, you and I should take a quick diagnostic timeout, because there's so much going on. And Franco is not smiling or giving us any clues with the way he's presenting the case. But, and by the way, I think Robbie is going to really wish he was awake and co-discussing this. This is like a Rob B, Rob B, not Rob V special, although it's a Robbie and Reza special too. But Ravi, like, I think like a case like this, you sort of step back and you're like, okay, how can I create a problem representation? What is so relevant? You have a young woman, no significant past medical history. You have inflammation. You have pancytopenia, and you have likely infiltration of the liver, spleen. And like you said, I think the bone marrow, I think you have an infiltrative process because of the alk-phos elevation, the enlarged liver, the enlarged spleen, the absence of like obvious signs of cirrhotic or non-cirrhotic portal hypertension. So basically my mind is saying inflammation, pancytopenia, enlarged liver, enlarged spleen, something's infiltrating. Now what that is, the question then becomes, I think, Ravi, like, can you get to a diagnosis without obtaining tissue? Like, are there certain studies we can send that potentially would diagnose this patient quickly? Or is it ultimately going to come down to getting that bone marrow biopsy or doing that liver biopsy to sort of study the tissue for organisms, for cancers, like you mentioned? But yeah, I was curious, like your thoughts on the salient features or anything else to add?
Yeah, definitely. If we were to ask a hematologist, maybe they would go for the bone marrow and see what is in the bone marrow. If, especially like you mentioned, where would be biopsy? I don't think I have enough of an idea to sort of make a superficial diagnosis. I think we have to go to one of the areas to see where could we get an answer. The lymph nodes are enlarged. Could lymph node biopsy disclose the diagnosis? Is the bone marrow the place where we can get the diagnosis? One other thought that came in was TB could potentially manifest as this, but then again, you had the acid-fast bacilli negative in the sputum and stool, but then that still could be a false negative. But again, we may have to get tissue then to really identify what may be at play here.
Interesting. And one other thought that came to me is these atypical lymphocytes, like we don't see them often. And that just makes you pause. Like we once had a case of Hodgkin's lymphoma that Robbie and I discussed. I don't even remember where we discussed it, but one of the clues were these like unusual lymphocytes. I don't want to put too much emphasis on that one data point. It didn't make its way into my problem representation, but once Franco shares with us what unfolds, I'll cross-check it to see if it should have played a more significant role besides like mononucleosis, drug-induced hypersensitivity syndrome, and just thinking of lymphoma and whether that should have tipped us in one way or another. But I'm very curious to what Franco has to share with us now.
Great. I will also answer some questions that were in the chat. So a lot of you asked for Epstein-Barr serology. We do took Epstein-Barr serology. It was positive for IgG in the viral capsid antigen, and the IgM was negative. The early antigen was also negative. Unfortunately, we didn't have like the capability to determine if there is a viral load of Epstein-Barr. So I only have those. But this time we already had the pathology of the appendiceal mass that was non-contributory, just inflammation and anything else over there. But we do got a myelogram that show increased iron deposits with moderate hemophagocytosis and a mild hypoplastic show. Also, the GI team performed a proctoscopy that showed ulcerate rectal mucosa and with no masses, but the pathology of that shows severe chronic inflammatory process with some atypical lymphocytes. We also performed a flow cytometry that showed non-phenotypic alteration in T, B, or natural killer cells. And I think I can stop there, and I will have the next aliquot, I will give the final diagnosis with one test.
Robbie, I'll give you the mic and let's play a little ping pong. What are you thinking? And we'll go back and forth, my dear friend.
Yeah, I probably have the pong part of this, but because looking at this, so this myelogram business increased iron deposits with moderate hemophagocytosis. I don't know, just that term makes you think about HLH. But you know, one of the episodes you had mentioned, you know, ferritin elevation you see that a lot of times as acute phase reactant, and it's very obvious for us to just sort of latch with that and just run with it and think about HLH. It's a very convenient diagnosis for a RLR, a VMR exercise. But you know, there's something else going on, or something that could be explaining it. But then again, superficially, at this age range, with many of these, there's quite a bit of non-specific signs and symptoms. But then this pancytopenia, going back to that pancytopenia business, you know, again, something's in the bone marrow, something's going on, and also linking to the hepatobiliary tree. And then it's appendicitis. So that's sort of like what you could term a pseudoappendicitis. So again, what do you have in the appendix? Lymphoid tissue. So I don't know. What would you say? Any ideas, especially with this proctoscopy and these rectal ulcers? Does that ring a bell?
Yeah, this can only be one diagnosis, but I have no idea what that diagnosis is. So I think what we have here, and this is such a great case, Franco, thank you for presenting it. We're going to definitely grow from this. I think with, you know, the ferritin being elevated, the triglyceride being elevated, the pancytopenia, the hemophagocytosis, you're meeting a lot of the criteria for HLH. So the splenomegaly. So I think this patient has HLH. You could also send, you know, the soluble receptor level and the NK cell activity. But then the journey just starts. It's like when you diagnose iron deficiency, it's like, why is it HLH? And I think when you say, why is it HLH? I'm just not getting a flavor for an autoimmune phenomenon. Like I'm thinking either infection or cancer. And when you have cancers, the one that really, like, I think is one that we need to consider significantly is lymphoma. Lymphoma, when you think about it, you can always get an LDH. Oftentimes you'll have lymphadenopathy, but not always. So lymphoma can be very compatible with this entire clinical presentation. Whether it's Hodgkin's, again, I don't recall there being a lot of lymph nodes, non-Hodgkin's, and yeah, Hans, I agree, T-cell, diffuse large B, who knows, but lymphoma is definitely consideration. I would send an LDH, but then infection is right there with lymphoma. And I can't wait to learn from Franco if there's a way we could have prioritized one or the other. And infections, specifically granulomatous infections. So these are, you know, your, like Ravi was mentioning, your tuberculosis, your parasites, your fungal infections that might be more prevalent there, like from histo to paracoccidiomycosis. And I think, you know, what's crazy, Ravi, I think the final diagnosis has to be one that commonly mimics appendicitis because it's involving that. So like there are specific infections like TB, Yersinia, I think some other ones I don't want to miss.
I think was it?
Oh, please, yes.
Enterobius vermicularis, that also gives you pseudo appendicitis.
And so I think that infection, that granulomatous process is invading. So it's either lymphoma or an infection that's invading the liver, the spleen, the bone marrow, and maybe the vessels causing those ulcers in the perianal area. As far as like IBD causing all this, it seems a little too much for IBDs. At least my gestalt is telling me that, despite there being ulcers. So I'm worried about either an infection or a cancer infection, either fungal or mycobacterial, and everything just precipitating this sort of hyperactive immune system. But that's all I have, Ravi. Anything else to add before Franco sort of teaches us like what they were thinking and how to prioritize one over the other?
Yeah, I'm going to jump on your bandwagon. I think you showed us sort of a nice journey through HLH, and it makes sense. So this is not, you know, when we think about HLH, there's primary causes, but we're dealing with a secondary cause. And I really like to know, what is the trigger if this is HLH? And I think also other parameters that would help in the diagnosis. I think fibrinogen also helps as well. Like you mentioned, LDH also helps in narrowing down the focus to HLH. But what exactly is causing this? And you nicely had demonstrated the lymphomas, leukemias, and then a vast array of infections could potentially cause it. And then autoimmune phenomena. So lupus comes to mind. I mean, there's a whole laundry list of things that I don't remember, but definitely if we open up a schema, we can probably investigate all of them. But I guess that's probably where I'm going to stop. And if you have anything else to say, Reza, I guess say it
My
now
last
before
thing
Franco
is,
tells us.
I want the audience just to know that Ravi, like literally, I just asked him 1 minute beforehand if he would be my co-discussant. So please send him a round of applause. It's been such a joy discussing this case with you, Ravi. Thank you for joining me, my friend.
Oh, my pleasure. Thank you.
Great. I really love how did you both of you tackled down this case. Also, the audience was really active and the chat was on fire. So, this patient had a HLH. So when you have HLH, you kind of in a hurry because HLH you have to prioritize treatment over diagnosis. And the main pivot point is that is this infectious driven or this is autoimmune or this is a neoplastic driven. So the high risk of HLH is that you need to treat it, and you treat HLH as it was a cancer per protocol. So the main pivot point is that you need to rule out infections first. So, but there was going to be a point where you are confident enough to have ruled the most common infections and start treating HLH. So in this case, we have everything negative for infections, no mycosis, no TB. The Epstein-Barr virus was kind of unrelated to have a viral load that has an active like a picture of Epstein-Barr, and if she got an active picture of Epstein-Barr, antiviral will not do the trick. You have to treat the HLH. So she was started on HLH protocol, and later on we received a T-cell receptor rearrangement study that showed that was positive for monoclonal rearrangement. So after meeting with a lot of hemong doctors, we finally came out that this could be an enteric T-cell lymphoma with HLH. That was mimicking the appendicitis in the first place. So it was a lymphoma that drive the appendicitis, and then everything went south when just was the surgery and that drive the HLH.
Wow, mind blown. I'm interested to know how the patient did, but Hans actually had put T-cell lymphoma in the chat during our discussion. So incredible job, Hans. I'm going to give the mic to Ravi, and then after Ravi's done discussing, maybe Franco, you can update us on the course and pass the mic to Shema to take us home with the teaching points.
Yeah, that was incredible, Franco. I really appreciate the case. Definitely, it's a whirlwind journey through so many different areas, and definitely, it was a pleasure to share the lukewarm seat, I'd call it, with Reza. It really put you on the spot, and really have to think through what could be going on. But a very humbling case, and I definitely learned a lot. And again, the gut, there's just so much going on in the gut. The mucosal associated lymphatic tissue, sometimes we don't even hone in on that, but that could explain a large variety of different illnesses. And it's lymphatic tissues, and lymphoma, surprisingly, in that area definitely could explain something like this. Again, really appreciate the case, Franco. Thank you.
So regarding the patient, unfortunately, the diagnosis was the treatment of HLH was really delayed. So she went into the ICU, she got overinfected with some bacteria, and she eventually passed.
So sorry, Franco, did you say she passed?
Yeah,
Oh, okay.
because she got infected in the ICU. She didn't support the HLH treatment.
Man, that's very, very sad. Very sad, very young. patient, well, may she rest in peace. Thank you, Franco, for presenting it, educating us, so we'll all be better for the patients that we encounter in the future. I'm going to give the mic to Shema to take us home with the teaching points. And yeah, thank you all so much for today.
Hello, everyone. So it was such a great case. Thank you, Franco. Also, Reza and Ravi, you did a great job as always, and the chat was on fire. So starting with teaching points. So we had as a chief complaint, post-operative fever. And as Ravi taught us about the 5 W's to consider, like water, think of a urinary tract infection, wound, an infection on the surgical incision, wind, something like pneumonia, atelectasis, or wonder drugs like drug fever related, or walking, thinking of DVT. If we have fever and abdominal pain, the 2 buckets to consider, the first thing, was it related to the appendicitis in this case, and a post-surgical complication, or was it or was the fever not even related to the appendix? And then we had rectal bleeding and jaundice. We were thinking, is there any GI or hepatobiliary tree issue? So we were looking for the focus. And in terms of jaundice, as you know, it can be due to indirect, or we can have the indirect or direct hyperbilirubinemia. And hepatomegaly made us prioritize direct hyperbilirubinemia, and other clues could be dark urine or acolic stool. In terms of perineal ulcers, consider diabetes mellitus, venous stasis, peripheral artery disease, or an extraintestinal manifestation of an inflammatory bowel disease. And also think that Behçet's disease can also mimic Crohn's disease. And also what Ravi said, the skin reflects internal diseases, so consider an inflammatory or autoimmune disease. The patient seemed to have inflammation due to high temperature, tachycardia, and we were also thinking of the tachypnea, as Reza said. It can be a pulmonary involvement, or it could also be something compensatory, like in terms of lactic acidosis, where we have clear lungs. In terms of hepatomegaly, is it congestive, like heart failure, inflammation, like hepatitis, or any infiltrative process? In terms of splenomegaly, consider water, something like portal hypertension, an infection like mononucleosis, autoimmune, myeloproliferative diseases, or molecules like amyloid. And in terms of hypernatremia, it's actually always a water issue unless you drink seawater, as Reza said. And there are also these 3 A's to consider, like the lack of access to water, altered mental state, and adipsia. And also think of diabetes insipidus, or generally water loss. Isolated alk phos elevation makes us think of an infiltration of a biliary canicula, as Reza said, and that's why we don't have any damage to the hepatocytes, so we wouldn't see any elevation of the AST and ALT. Then we had hyperferritinemia, and the differentials are HLH. And as Franco said, always rule out an infection, and also consider autoimmune like AOSD, hemochromatosis, or generally inflammation. And the criteria for HLH fit here because we had very high triglycerides, pancytopenia, and also consider other criteria like elevated soluble interleukin-2 receptor, low fibrinogen, and also in terms of HLH, it can be primary or secondary like lymphoma in this case. And also what I remember from Sammy, CXCL9 as a marker makes HLH very likely in hyperferritinemia. And yeah, and the differentials for this case, like pancytopenia, infiltration of bone marrow, liver, and inflammation are lymphoma, and consider LDH elevation. And also what Reza said, we don't always have lymphadenopathy, and also think of a granulomatous infection like mycobacteria, histopericoccii, and also note the mimics of appendicitis, as Ravi said, TB, Yersinia, or Enterobius vermicularis. So thank you very much. I'm finished.
Incredible job, Shema. I just wanted to say that was very nice teaching. You captured it all and you added. So thank you for that. I also want to let Ravi know my brain is absolutely fried. I want some pizza. I want some Coke. I want to be, dopamine to recover. And then I just wanted Rafa, if you're on, Rafa, if you can unmute yourself and tell us what's happening this weekend. I hear we're taking a trip to Argentina. Or did Rafa leave? He might have left.
Yeah, I'll just fill in. Yeah, we have a global VMR with a program from Argentina, and then Sunday we don't actually have a student VMR. We actually have boot camp, so we welcome everybody to join us. Camping, we're going to be doing an exercise in clinical reasoning. Franco, Shema, Deborah, Madalena, Marcella, all of them will be teaching us the illness script. So definitely join us on Sunday for that. Take care.